And this was published in 2007, and this showed that the low-dose tacrolimus group had a higher mean glomerular filtration rate, significantly higher than the other groups, with a lower rate of biopsy-proven acute rejection. You can see the low-dose tacro group here, low-dose sirolimus, you can't really see the line, but the line is going up here, and the standard low-dose cyclosporine somewhere in the middle. This was reflected with improved allograft survival, although this was only reported at 1 year at that stage, and a lower treatment failure than the sirolimus group. The sirolimus group came out quite badly in this study, with a higher number of adverse effects and quite a high number of patients switching from sirolimus to other therapy. So the early results of this study were encouraging. At 3 years, the same group carried out sort of an observational study. So again, the main study was powered for results at 1 year. So they described an observational study reporting on the results of the SYMPHONY study at 3 years. 58% of patients were followed up for the 3 years. And in terms of the maintenance of their immunosuppression, the majority of patients remained on MMF. Individual centres were allowed to undertake steroid withdrawal according to their own protocol, so 28% of patients had steroids withdrawn. And this graph just shows the number of patients that switched from the different groups. And all I wanted to say is, again, that quite a few, this is at the time of the original trial, the middle bar is at 1 year, and the white bar is at 3 years. So quite a few patients switched from sirolimus, mainly to the low-dose tacrolimus group, and again there was a fall-off in the cyclosporine group, again taken up by tacrolimus. So there was quite a lot of move within the groups. And at 3 years, again this is an observational study which wasn't powered to look at this, all groups were found to have stable renal function, roughly the same rates of death, graft loss and acute rejection, and each of those were about 1%. There did seem to be continuing improved renal function in the low-dose tacrolimus group. Again, the line for the tacrolimus group doesn't project terribly well, that's it up here. But the majority of that impact seems to be early on, and the difference at 3 years between the groups was not statistically significant. And again, there was no difference in graft or patient survival. So these early results from the SYMPHONY study have perhaps not been borne out over time, which is a little disappointing. So the future challenges for our immunosuppressive regimes have got to be working towards this lower toxicity and powering our studies for longer term endpoints. And I know there's a lot of discussion and a lot of moves trying to identify what are really good surrogate markers of long-term outcome. There are novel therapies around which are currently under study, bortezomib, which is a proteasome inhibitor, alemtuzumab or Campath, which has been around for some time but hasn't quite found its niche yet, and the anti-B-cell, anti-CD20 antibody rituximab. So having established, as I say, very effective immunosuppressive regimes at reducing acute rejection rates, we're then faced with a heavier burden of the complications of immunosuppression. And this is where I'm just going to spend a little bit of time looking particularly at the management of cytomegalovirus, which is a significant contributor to morbidity and to mortality following transplantation. And over the years, there has been a quest for an appropriate prophylactic agent. And again, this was an early study published in 1989, which was a randomized, placebo-controlled trial, oral acyclovir for the prevention of CMV. And this showed a significant reduction in the incidence of symptomatic CMV disease compared with placebo, and in the incidence of CMV infection. And this was the benefit was seen most in the donor-positive to recipient-negative group. So this is the highest risk transplant recipients for CMV infection. And this really established the scene for acyclovir being a useful agent in prophylaxis for CMV disease. And we've gone through several generations of similar drugs, and most recently there has been a study which compares oral ganciclovir, which is, again, has less affected by availability, versus valganciclovir in CMV prophylaxis. And this, again, was really just a study looking at the efficacy and safety of valganciclovir and showed similar efficacy with comparable rates of disease. Interestingly, there seemed to be a delay of onset of disease with valganciclovir and lower rates of acute rejection. And again, what this has demonstrated, and I think which has become a point of discussion within transplantation, is how long should these patients be managed with CMV prophylaxis. Traditionally, we've managed our patients for 3 months, but what these studies have demonstrated is that actually what you're doing is you're delaying the onset, often delaying the onset of CMV disease rather than preventing it altogether. And so in some centres, we're now increasing the period of time in which patients are managed with valganciclovir post-transplant. Just briefly to mention the treatment of CMV disease, the established treatment for CMV disease would be 2 to 3 weeks of intravenous ganciclovir, which of course is significantly inconvenient for the patients requiring daily IV treatment. And a recent study, which is a randomised trial determining the effectiveness of oral valganciclovir treatment, in which patients were randomly assigned to either IV ganciclovir or valganciclovir. And again, this was powered for efficacy and safety, and so they seem to be similarly effective at suppressing viremia at 21 days. And recently, an update has shown that they're similarly effective at 1 year. One of the problems with this trial is that the patients are being managed on many different immunosuppressive regimes. We do not have a unified immunosuppressive regime, and so it's actually difficult to establish just exactly how relevant and reliable the results from the Victor study are. Finally, I'm going to talk about some of the various surgical or technical aspects of transplantation. And this was a study that was published just a year ago, at the beginning of January 2009, by the European group. The traditional mode of organ preservation has been static cold storage, so organs are flushed with preservation solutions such as University of Wisconsin solution and are stored for transport at about 4 degrees. And this trial was a randomised controlled trial of 336 deceased donors. Obviously, kidneys have a significant advantage in there's 2 of them, so you can randomly assign 1 kidney to cold storage and the other to hypothermic machine perfusion. And the 672 recipients of those kidneys were followed for a year, and the primary endpoint was delayed graft function.